So I'm going to hand over to Gina, and I'm going to close the computer. You will need to, but yeah. I'm going to hand over to Gina, and I don't know that Gina needs much of an introduction. I think most of you have probably read the write-up and know Gina has been around for a very long time. For a very long time, she was the CEO of the Association for Professional Behaviour Analysis in America, which has done fantastic work for the profession and professional development. Funding for people with, especially for people with autism, to receive, to be able to access ABA-based interventions. In America, every single state has a law to say that health insurance, you know, they have an insurance system in America for health, so that health insurances have to pay for the medically necessary interventions, and when it's identified that these kids need these interventions for medically necessary reasons, then they can get funded for ABA. That was wonderful when that first came out. We were all really, really envious. Of course, that has also got its problems, but generally speaking, Gina has been at the forefront of getting the profession developed in America, and I'm just going to talk on here. Just carry on. Somebody stop me. To help getting the licenses for behavior analysts in a whole number of different states. Maybe we'll hear about that. Are you done? Are you okay to start?
Yeah, I have to plug in.
Yeah. Okay.
Where's the mic? It's always a challenge because we have bad karma for all things electronic. See how we go here. Doesn't seem to be reading my. All right, can everyone hear me? Good. I am beyond thrilled to be back at Queen's. The experience I had getting an honorary doctorate almost 20 years ago was surreal in a wonderful way. It was really, one of the biggest honors of my life, my professional career for sure. And a lot of that had to do with the grace and kindness of everybody at Queen's, and everybody was responsible for that. So I wish it had not been 20 years, but I'm glad to at least have made it back while I'm still able to travel. So thank you all for coming. Thank you everyone who's been supporting the center and supporting this conference. I am going to talk today about intensity and outcomes in ABA intervention. Probably many of you know this already, but by treatment intensity, or sometimes called dosage, I'm going to talk about what that is, why it matters for children diagnosed with autism, say a little bit about the kinds of studies that can produce credible evidence about effects of intervention, including intensity or dosage, and then give you some new information, I think, or at least some summarized information on the best scientific evidence we have about the relationship between intensity or dosage of ABA treatment and child outcomes, mainly for young children with autism. And then I want to give you a little bit of information, if I have time, about what we call in the United States, within our crazy healthcare system, there's a lot of talk about a term called generally accepted standards of care. And we do have standards in that large umbrella, generally accepted standards for ABA healthcare for children with autism. And I'm going to just give you a little flavor about those, what they say about treatment intensity and how they were developed, and then you won't be surprised, I'll have some suggestions at the end. So by treatment intensity, what I mean here is, and as it's defined in the research, I've got water, thank you, is typically defined in terms of the number of hours per week that a child with autism, or any client, is receiving active, direct intervention. So it's not the time somebody's training technicians or parents, it is the time working actively with the child. And really, the number of hours per week is a proxy or a stand-in for the number of learning opportunities, or if you want to think of them as therapeutic interactions per unit of time. That happens to be a lot harder to measure than hours per week, which is hard enough to capture. So why does this matter, in particular for young children diagnosed with autism? How many of you have worked with children with autism or have them in your families, among your friends? Excuse me. So you know that most children, when they're diagnosed, have delays in multiple areas. Cognitive skills often, communication skills, early social skills, and just lack many sort of basic daily living skills. So it's when children are young, if we can deliver effective intervention, then that gives us the best opportunity for them to develop the skills that are essential for successful functioning in school and even beyond that, for a number of reasons. When children are young, of course, they're, again, with developmentally delayed children with autism and other diagnoses, there's already a gap between their skills and those of their typically developing peers. That gap is just going to widen over time if we don't do something about it. And as time goes on, if efforts have not been made to shrink the gap, it's just going to become more difficult. The other thing is when children are young, their challenging behaviors, problem behaviors are not yet so firmly entrenched in the repertoire, so it's easier to work with them on ways to reduce those. And there's a lot of evidence that with both typically developing to all young children, a lot of brain development is going on when they're very young, really critical brain development. And there's evidence that the way the brain develops, surprise, surprise, is highly influenced by interactions with the environment. Experience influences the neurology. So this diagram that I've shown here it kind of depicts that. So you see the rate of development on the vertical axis, and along the horizontal axis, age. So with the typical trajectory, of course, children are gaining a year in skills for every year that they're alive. Developmentally delayed children start out, usually with children with autism in most studies, they're functioning at about 50%. Their developmental rate on average is about 50% of that are their typical peers. Sometimes it's even more severe. And their trajectory is going to be much, much different than typically developing peers without intervention. So why is treatment intensity important? Well, I mean, it's important in a lot of different realms, but in this one in particular. But if you think about for yourself, if you've ever tried to learn a new skill or change a bad habit, I think you'll acknowledge that it takes a lot of opportunities, right? You have to have a lot of practice. You have to get specific feedback from other people, from your physical environment. So, and this is validated in tons and tons of research that it takes a lot of repeated opportunities with feedback for behavior to change to begin with, much less to carry over to other situations and to maintain over time and so on. Children who don't have developmental delays are learning from their environments all the time. Nobody has to do anything special for that to happen. Parents and others are constantly arranging opportunities, giving kids feedback. Again, the physical environment gives them feedback. So they're really learning throughout all of their waking moments. For young children with autism, we have to make that happen. So we have to arrange the environment to promote and encourage the skills that other children develop seemingly automatically, such as looking at things and looking at people, listening, imitating, and communicating. So we have to arrange those opportunities very, very carefully and explicitly. And for most children, because they have difficulties in multiple areas, the treatment is going to need to be comprehensive. It's going to need to address cognitive skills or intellectual skills, communication skills, social skills, again, all of those basic daily living skills. And for young children, what a lot of us emphasize in early intervention is what we call learning to learn skills. The basic listening, looking, following instructions, imitating, and so on. And so if you're going to address many skills in many areas, you have to have a lot of, again, the child has to have lots of opportunities, planned opportunities for that. It's simply going to take a fair amount of time to do that properly. So how do we figure out what is effective? How do we know what levels of treatment intensity and other aspects of treatments are helpful for any kind of client or patient? But of course, I'm still here focusing mainly on autism. First, we want to look for studies that are prospective. I mean, the study is done from a point in time forward. So there's a research question, the study is planned, participants are identified, procedures are all carefully planned out, and it again proceeds forward. I'll contrast that, I'll come back to this in a few minutes, with retrospective studies, meaning something done after the fact where people look at records that were usually collected for non-research purposes, educational records, healthcare records. There's no control, there's no, again, forward-looking study. That's a bit different. And speaking of control, we also need to see that the study is controlled, meaning that there needs to be an experimental group or condition and at least one control or comparison condition. So you have individuals who are going to receive the treatment you're interested in and individuals or a group who will receive some other form of intervention. You can do that using various kinds of designs, group designs, single case designs, or both, or combinations. But you have to have that kind of control to be able to compare what happens with the treatment versus without the treatment or with a different treatment to draw any conclusions about effects of the treatment of interest. And again, you contrast that with various kinds of uncontrolled studies where there's only a group of people maybe who get the treatment, case reports, anecdotal reports, surveys. Surveys are not controlled studies in any form. Another thing that's essential for studies that results we can hang our hats on, if you will, we want to see how the outcomes are measured, the client's outcomes, perhaps in some cases parent outcomes as well. And if you take a look at the good research on autism intervention in medicine, many other fields, you'll see that good researchers use standardized assessments. These are assessments, instruments, or procedures that have been developed in particular ways and have been shown to be generalizable. That is, you can compare the results across many people, across different examiners, across time. They can be norm referenced, meaning an individual's performance is compared to the performance of a large group, large sample of other people. So, for example, IQ tests. Individual scores compared to a normative sample of people of the same age. Or they can be criterion reference, where the individual's performance is compared against a predetermined and carefully evaluated and selected standard or criterion, such as proficiency in performing certain tasks. Academic achievement tests are of that sort. Licensure certification exams in professions are criterion referenced as well. We want the instruments to be valid and reliable. I'm not going to go into all that's involved there, but that's it's essential to be able to consider the results to be valid and true in a sense and reliable, meaning they're consistent. And in the best studies in the autism world and many other areas of healthcare, education, and so on, you see assessment instruments that are administered directly to the individual patients or clients. And for example, in this world of autism intervention, direct assessments of their autism characteristics, often of cognitive skills, communication skills, social skills. And in addition to that, but not just indirect assessments, these would be assessments or scales that are completed by somebody else, by a parent, by a teacher, by the behavior analyst. It's their impressions, if you will, of the person's skills. So if you're familiar with adaptive behavior scales, the Vineland Adaptive Behavior Scale and others, those are completed by third parties, so they're indirect, various other rating scales and so on. And of course you want to take a look if you're reading a study to see if their outcome measures have these characteristics and are appropriate to the group of people who, or the individuals who participated in the study. So some tests are designed only for people of a certain age or with certain diagnostic characteristics and so on. And then we're evaluating studies. It's important to look at how the data are presented and how they're analyzed. So in studies using group research designs, who have a usually sizable group of people who are going to experience the treatment of interest, and a comparable group is going to experience a control condition, no treatment, or typical services. And in those kinds of studies, almost always you're going to see statistical comparisons of the average scores of those two groups. And that's fine. Those kinds of statistics are good ways of giving us a big picture. They summarize what happened overall, and again, usually on average, to the people in each group. But they don't tell us how well the individuals did. How many individuals improved with treatment, got worse with treatment, made no change. Can't tell that from aggregated group statistics. And then I know all of you good graduate students in the audience. This will be review for you that statistical significance does not equal clinical significance. So just because you can get statistically significant differences between two group averages doesn't tell you anything about whether any improvements by the individuals, let's say in the treatment group, were of any clinical importance, significance to them or to their families. So it's ideal, it's best if we find studies that also tell us if they use group statistics, or if they don't, they tell us what happened to the individuals, how were they affected. Often this is represented in graphs so we can visually see, and I'm going to show you some examples in a minute. You can also do kinds of statistics with individual data to show the direction and the size of changes people experienced over the course of a study. And in really good studies, you see both the group statistics as well as analysis of individual results. So again, some examples. We have now many, counted them up lately, controlled, prospective, group design studies with good outcome measures that have been conducted by scientists and scientist practitioners in multiple countries, comparing comprehensive and intensive applied behavior analysis for young children with autism with treatment as usual. So this would be typical early intervention services or typical special education services. And we also have studies that compare that comprehensive intensive ABA with what's often called eclectic intervention. This is a mixture of therapies, so maybe a little ABA, a little occupational therapy, a little speech therapy, and others. But no single study, having said all this, tried to describe to you what would be a good study. No one study is going to give us enough information to draw large conclusions about effects of any intervention. So we need to see evidence from multiple studies with those features I described, ideally conducted by different sets of researchers independently. So you want to be careful if you see studies done by the people who developed a program or intervention, and the only other studies are by them and their students. We see people, truly independent researchers, replicate. So we look for sources that summarize evidence from multiple studies, where those studies have been identified and reviewed and analyzed very carefully by people who are experts in the treatment of interest and also in the research methods. Those can take the form of systematic reviews. These are sometimes called narrative reviews, where people just summarize, here's all the studies, and overall this is what they show. Or meta-analyses. Now, meta-analysis is simply a set of methods, systematic methods of combining data from multiple studies, usually multiple published studies, and doing some statistics to estimate the effect, how large the effect size is for an intervention, for example, what the overall outcomes are. Now, there have been, by now, a lot of good meta-analyses of studies on both the comprehensive intensive ABA intervention for young children with autism and what we call focused ABA interventions, which would be targeting just a small number, perhaps, of challenging behaviors and adaptive behaviors. What I'm going to talk about now from this point on is about the comprehensive and intensive version. Just a word of caution, how many of you have read meta-analyses? All you doctoral students and postdoctoral students, I hope. So you probably know that the results can vary. It depends on the biases, honestly, of the authors, which studies they decide to include or exclude, the interventions they're considering, and so on. So just because it's meta-analysis doesn't mean it's good or that we could really believe what the results seem to show without digging into it. There have been some meta-analyses, I'm going to talk about a couple of these, or at least one of them, that purport to evaluate large numbers of studies on early intervention approaches for kids with autism, and even some that say they're on ABA, but they haven't clearly defined what that means. So the best of the meta-analyses, again, we're just wanting to see what do we know, what is the best evidence on ABA interventions, then the interventions need to be clearly behavior analytic. There are lots that are said to be behavioral or even based on ABA that don't have the defining characteristics of behavior analysis. We want to see that the participants were similar. So if we're talking about early intervention, all the participants in the studies should be young, right? Not a mix of young kids and adults. And either all of the interventions should be focused, so just a few skills, a few challenging behaviors, or comprehensive, focusing on many different skills and different domains, but not both. So now to the best available evidence we have at this point in time on ABA treatment intensity, again, for young children diagnosed with autism. There have been a number of reviews and meta-analyses already showing that approach, that intervention model, produces larger improvements overall than lower intensity ABA, than eclectic or mixed therapy intervention, and then typical services. This has been quite well established for a long time. What I'm going to now jump to is a brand new meta-analysis. Some of you may have seen a meta-analysis published in 2010 by our colleague Sigmund Eldevik from Norway and his colleagues. This is an expansion and update of that analysis. One of the big strengths of this approach, of the way these Norwegians have gone about it, is that they have not taken group average data from published studies. They've gotten individual participant data from the researchers themselves with personal information redacted, of course. And so they can do a much more fine-grained analysis. So they have assessment results on individual children in multiple studies. Now, this paper that you see referenced here is currently under review. I don't even know which journal, but Dr. Eldevik has very kindly given me permission. We've presented together a couple of times, and he's given me permission to share some of his actual slides from recent presentations summarizing data from this meta-analysis. I'm also going to cite a new white paper by the Council of Autism Service Providers, which is a nonprofit autism trade association. I mean, it's made up of agencies that provide services for people with autism in the U.S. And you'll be getting a copy of these slides, but this white paper on treatment intensity is freely available on the CAST website at that URL. So what Dr. Eldevik and his colleagues have done is analyze data on 341 young children with autism. They were participants in 15 separate studies, all of which have been peer-reviewed and published in reputable journals. These were all prospective, controlled studies, right? In all cases, they were careful to include only studies where the intervention was actually behavior analysis. So it was designed and overseen by professional behavior analysts. It addressed all skill domains, was individualized. And what they did for this new meta-analysis is group the children into levels, into groups according to the dosage or intensity level of the treatment that was provided in this study. So they defined low intensity ABA as 5 to 12 hours a week of direct intervention, moderate 13 to 25 hours per week, and high 26 to 40 hours per week. The measures, different researchers have used different measures, but there's a fairly common set of standardized assessments that have now been used in many of these studies, and they include tests of intellectual skills, IQ tests, individualized to the children's ages and developmental levels and so on, the Vineland Adaptive Behavior Scale, and for this analysis they used the composite, which is the overall performance of adaptive behaviors, and a measure of autism severity, the Childhood Autism Rating Scale, which gives you an index of the severity of autism. And they looked at the data. Some of these studies, children who received intervention for 2, 3, 4 years. They looked only at 1 year, right? And you're going to see average changes in standard scores. They also considered whether the improvements that were reported were clinically meaningful. Did children make large enough improvements to enable them to function well in school without help and beyond? So here we go. First graph from Dr. Eldevik. What we have here is the Vineland Adaptive Behavior Composite Score. Again, this is aggregated across all the individual kids. And then the weekly hours of intervention along the horizontal axis. Some studies are identified by the names of the first names, the last names of the first authors of the studies. So each of those dots represents the outcome or result on the Vineland Adaptive Behavior Composite in a study. And the dotted line is the best fit line, and what this, I think, shows pretty clearly, that the higher the intensity, the larger the improvements in adaptive behaviors. Adaptive behaviors also encompasses maladaptive behavior, if you're not familiar with the Vineland, basic skills of getting along in the world every day, as well as maladaptive behaviors. This is a similar graph representing changes in IQ. Now, I know there are lots of limitations to IQ tests, but it turns out that scores on the Vineland and scores on IQ tests are actually highly predictive of functioning in school, of functioning in adulthood, holding jobs, completing school successfully, and on and on. So these are super important measures. Again, we see a few studies identified. Each dot represents one study's reported changes in IQ scores. And again, the higher the intensity, the more the intervention, the larger the gains in intellectual skills. This one goes the other way because this is the CARS, the autism index. You want the scores to go down because decreased score means less severe autism, right? Less severe symptoms. And there were fewer studies that use this measure. That's why you see so few dots here. But again, that bottom axis is, it says weekly hours across the top this time. As intensity of treatment increased, autism severity decreased, right? So again, pretty clear relationship between treatment intensity and a very important outcome. This is another way in which Sigmund and colleagues have summarized their meta-analytic data. So what you see here, the blue bars represent children who got low-intensity ABA. The red are the kids who got moderate, 13 to 25 hours a week, and the green are the kids who got high-intensity ABA. And you see in the table there that, you can see in the bars, for example, that the adaptive behavior composite, the ABC change scores, increase with increased intensity. The mean IQ change increased with increased intensity. And the CARS, again, we want that going the other way, that also improved with increased intensity. Clearly the highest intensity, showing the largest improvements. Sigmund and colleagues evaluated the data in terms of the proportions of children in each intensity group who made so much improvement on each of the measures that they moved from a clinical range into a non-clinical range. Now, most of the kids made improvements, always, even those who did not move all the way into the normal or non-clinical range, still made improvement. But again, here we see the green bars show the pre-test, so the baseline. And this is the IQ score. So what the green bars show you is that the children who ultimately got low, moderate, or high intensity treatment were very similar at the beginning of treatment. The purple bars show you how different they were at the end of treatment. And again, a pretty clear effect of treatment intensity or dosage. And this is similar for the Vineland. With little children, how many of you work with young kids with autism? So anyway, I don't know about you, my work, you work on some adaptive skills, but it's not as emphasized as other skills are. So we don't see as large changes on the Vineland with these kids as with maybe older children. But anyway, you see again, the green are the baseline scores on the Vineland. Pretty comparable at baseline. The purple are the one-year outcome scores. Again, higher changes with higher levels of intensity. And then finally on the CARS, the autism measure, again, they didn't have enough children in the middle group, the moderate intensity group, to make a sensible analysis here. So we just have the low and the high. Again, very similar at baseline. And not as big a difference, but still a difference with higher intensity. Again, on autism symptoms. So from this work, Aldbeck and colleagues have pulled what they call benchmarks. So they're suggesting that we now have enough data so that folks who are out there doing early intervention of any kind with young children with autism have these benchmarks. You can measure your program's performance against the best available evidence from really good studies. And so what this shows is, again, for the low, moderate, and high levels of intensity, I think you can think of this as if you have children getting low intensity ABA, this is about the best you could expect. That they would have changes that about 10% of them would move into the non-clinical range on adaptive behavior, about 20% on IQ, and about 20% with autism severity. So they're going to make some improvements, Their mean change scores are not, nothing to sneeze at. But then we go up a level of intensity, and we see larger percentages by a lot of groups of children who are likely to move from the clinical to the non-clinical range, and larger change scores. And then finally, for children who receive truly intensive and comprehensive ABA, much larger proportions in adaptive behavior and IQ, and larger change scores. Any questions so far? I don't want to just barge along here. You all look like you're getting it, fully understanding it, so good. I just want to, yes.
Is there any information, Gina, on the baseline skills level and severity of autism or anything in these studies?
Well, yes. So the children in these studies had all ranges. They were all on average functioning at 50% or less of the typical range. So you saw those baseline scores? They were all they were all pretty severely affected when they started treatment on average, and not so much after treatment. Yes, ma'am.
My only query is regarding the thing is that in the outcome, was it seen to be in real circumstances, or was it all done in an environment where the children could foresee what was going to happen because they work with a very much routine-based concept, or if it's outside of that, it could still be totally different to the actual researchers' findings?
Yeah, that's an excellent question. And by the way, I'm a co-author on a couple of these studies, so I can speak to that, but I also am very familiar with the others. The interventions, one of the defining features of good ABA intervention is that it's done in multiple environments. So if you start out working in a clinic or a center, or working in a home to start to build some basic skills, if you're a good behavior analyst, you're going to be working on those skills out in the community. You're going to be helping the parents work on those skills at the grocery store, neighborhood playground, at church, and of course, as the kids move into school, also in school. So that's the nature of the intervention, was that it was worked on. So these were not at university clinics for the most part. They were not even all in contained centers or clinics. Some of the kids started out in the home, some started out in a school or clinic setting. It just depended on the family circumstances to a large extent. Is there another? Okay, well, just to quickly provide some information about long-term effects. What do we know? So we have all this good information that good, early, intensive, comprehensive ABA intervention can make a big difference for many, not most, young children with autism. Do those effects maintain? Are they sustained over time? Well, it happens that there are at least two groups of researchers who have done long-term follow-up. So they have found folks who participated in early intensive ABA when they were young, and they followed them into adolescence and adulthood. And they again conducted assessments of their adaptive skills and other aspects of living. One was a group of researchers in Ontario, Canada. The other actually was done here in the UK, although some of the researchers are from Norway. And what they found, these two studies, so there were 21 people who were followed in the Canadian study and 19 in the UK study, and they found that for the majority of those individuals, the improvements that they had shown in their autism characteristics, IQ, their communication skills, and other adaptive behaviors at the end of their early intervention did in fact maintain all those years later. They also evaluated whether those folks had encountered additional difficulties in their lives. And none of them had received any other psychiatric diagnoses. None had below normal scores on assessments of their social emotional functioning, which these researchers conducted, and none of them were on psychotropic medications. So, pretty good evidence that the results maintain. How am I doing for time? I have 11:20.
20 past.
Good, 11:30. Just quickly, there are two studies. I don't know if you've heard about these here, but these are two studies published in the U.S. recently that gotten quite a lot of traction, in that they are claiming to show that you don't need intensive ABA. Low intensity intervention is just as good. Kids will do just as well as with high intensity intervention. The kicker is both of these studies are uncontrolled retrospective reviews of healthcare records from agencies that were paid to provide the services to the kids. So, not controlled studies. There's no treatment group, control group, or condition. It was all done in hindsight and after the fact. They selected what records they wanted to look at. In both of these studies, the main outcome measure was the third edition of the Vineland, and it was the parent version. The Vineland has a parent and a teacher version. Well, it turns out, and now again, that is an indirect assessment. It's not a direct assessment of the person's skills. It's the impression of the parent. Valuable information, don't get me wrong, but it doesn't necessarily always correspond to our direct measures of functioning. And the third edition of the Vineland has not yet been proved to be valid and reliable for kids with autism. So I don't think you can put much stock in their finding, and this was their main measure in these two studies. I thought it'd be interesting to look at, nonetheless, regardless of how flawed these studies are, how do their outcomes compare to those benchmarks I just provided from Eldebek and colleagues from those hundreds of kids. And so I've got the benchmarks here across the top for IQ, the Adaptive Behavior Composite Score, and the autism severity for for high intensity ABA. And in that first study by Ostrovsky and colleagues, the only thing they measured was the Vineland, the ABC, and they reported an average gain of about 3 points, whereas in the studies with intensive ABA, the average gain was 9 points. They didn't measure the other two outcomes. Similarly, in the SNEED study, they compared what they called parent-mediated ABA intervention with paraprofessional-mediated. It was all low intensity. Again, they only measured adaptive skills using the Vineland, and you can see they reported a gain of 7 points in the parent-mediated condition. I have reason to doubt that. They didn't use any other measures. In Ostrovsky, SNEED used the verbal behavior, the VB map, which I know is very popular among behavior analysts. It's not scientific. It's not developed according to good standards. It's not valid. It's not reliable. So, dubious. And then finally, this one, to me, you heard this one. Big meta-analysis of lots and lots and lots of studies of all kinds of approaches to early intervention for kids with autism by Sandbank and colleagues, published in a medical journal. This has gotten a lot of attention in the U.S., including among funders, health plans. And again, they concluded, they looked at hundreds of studies in a category they called behavioral. It's really unclear. It looks to us, a group of us have looked at the studies they actually included. Many of them were not behavior analytic at all. But they looked at this massive data and said, well, intensive treatment doesn't have any effect for any intervention for any young kids with autism. Well, that doesn't meet the smell test. It doesn't make sense, honestly. And so we dug into it and found that they had lumped together studies that were looking at just focused treatment, which is almost always going to be of lower intensity, together with studies that were comprehensive, so necessarily take more hours per week. They combined ABA and non-ABA interventions. Some of the studies didn't even measure child outcomes. They were parent training studies. They kind of mixed all that together. The participants, children in these studies, ranged in there was a pretty big age range in autism severity and other characteristics varied. The outcome measures varied. So it was really difficult to make much, glean much specific information from this giant meta-analysis. And so some colleagues, a research team led by psychologist Tom Fraser, reanalyzed the data that Sandbank and colleagues had reported, and this is what they found. They reanalyzed it using IQ as a factor, which Sandbank had not done, and found consistently significant, positive, and clinically meaningful associations between intervention quantity or dosage and outcomes when IQ is included. So when you factor in the children's cognitive skills, of course, lots of studies show that that's a factor that plays into how effective an intervention may be. And that paper, it's actually a letter to the editor of the journal, is published, and there's the reference for that one by Tom Fraser and colleagues. So in my last couple of minutes, I want to touch on those generally accepted standards of care. Is that a term that's used here or anything like that? No? Well, in the U.S., it is kind of a big deal. It generally refers to identified best practices for serving individuals with a specified condition. And these best practices are considered to be widely accepted by the professional community, medical, lots of them in medical care, people in the relevant clinical specialty. And therefore, they're developed by members of that profession, by people who are experts in that clinical specialty area and in the condition that's being considered. And typically, groups of those experts will analyze the best available scientific research and also talk with practitioners who are serving those patients or clients about best practices. So generally accepted standards of care actually referenced in many laws, healthcare laws in the U.S. We have laws that say that certain health plans, in deciding what are called medically necessary services, which is what drives health insurance coverage in the U.S. system. So what constitutes medically necessary services for children with autism, adults with substance use disorders, people with Tourette syndrome, diabetes, heart conditions, on and on, these laws say that health plans must consider the generally accepted standards of care from that clinical specialty in deciding what services they're going to pay for. So it's a big deal. And we haven't had these in our field in behavior analysis. Well, we have had. Take that back, because I'll show you. The current version are these. The Council of Autism Service Providers, I mentioned earlier, put out last year these applied behavior analysis practice guidelines. Again, these are specific to autism, but not to early intervention. This is for the whole lifespan. CASP, as I mentioned, is a nonprofit trade association. This is actually the third edition of these guidelines because we've already had them since 2012. The BACB, Behavior Analysis Certification Board, published the first version in 2012 and an updated version in 2014. They've taken on much more significance in the U.S. lately because of these laws that incorporate generally accepted standards of care. These guidelines are based on a review of the best available scientific evidence on all aspects of treatment, not just treatment dosage or intensity. There was a guidelines and standards executive steering committee involved. In full disclosure, I am on that. There was a separate practice guidelines committee and lots of other people, a total of more than 80 subject matter experts in behavior analysis, medicine, psychology, and healthcare law, and consumers, parents, and people with autism, all were involved in developing these standards. And I'm just going to highlight what they say about treatment intensity, since that's my topic. First, it has to be individualized. So it's not that every young child automatically should get 35 to 40 hours a week. You do a careful assessment. You determine dosage, just as if you were treating someone with a medical condition, and there's a drug that's effective for treating that condition, you figure out the dosage that's appropriate for that individual and other aspects of their treatment. And intensity should also be based on the scope of treatment, meaning whether it's going to be focused on just a few adaptive behaviors, challenging behaviors, or it's going to be that comprehensive variety addressing multiple skills in multiple domains. So the standard for that last, for the comprehensive treatment model, again, regardless of the age of the individual, is 30 to 40 hours a week. Best available evidence shows that's going to produce the best outcomes. They state that lower intensity comprehensive treatment really only applies when you're trying to maintain behavior change that you've already gotten with intensive intervention. So as you're basically talking about is fading out the services, children moving from the comprehensive intensive intervention perhaps into preschool or kindergarten or other forms of services. For focused ABA treatments, the standard is 10 to 25 hours per week, with the caveat that you might need more than that if the behaviors jeopardize the person's health or safety, the safety of those around them, or they have such deficits in their adaptive skills that their health and safety are jeopardized. And I like this statement in the standards: when there is uncertainty regarding the appropriate level of intensity, the practitioner should err on the side of caution and go with more intensive intervention. Can't hurt. Also, moving to a lower level of intensity, so from high or moderate to lower, is appropriate only when it's safe to do so, and when the lower level is equally effective as higher intensity treatment for that individual. So let me wrap up here. I hope you all agree with me that our consumers, families that we all serve, again, whether they have a family member with autism or any other condition, are best served when we help them make fully informed choices, fully informed decisions based on the best available evidence about whatever the intervention is that they're interested in. Credible evidence about treatments of all kinds comes from prospective controlled studies with valid and reliable measures. We need analyses of multiple studies to determine if a treatment is what's often called evidence-based. Actually, I don't like that term because it's used in so many different ways, but I prefer the term scientifically supported. It's one that the American Psychological Association has adapted. But the point is, we can't hang our hats on the results of just one study. Even as a great study, very well controlled, excellent measures, etc. We need multiple. We need replications across multiple groups of participants and investigators. We do have those kinds of syntheses of information from multiple studies, reviews, and meta-analyses of research showing that intensive, comprehensive ABA produces larger improvements in young children with autism than lower intensity ABA, eclectic, or typically available intervention. And the recent meta-analysis I summarized for you, which I hope will be published soon, by Dr. Eldevick and colleagues, showed that for 341 young children with autism, high-intensity ABA intervention clearly produced much larger improvements than moderate or low-intensity. Some of the studies and meta-analyses that have recently been claimed to show that intensity doesn't matter are not good studies. They're just flawed methodologically, so we should be careful about drawing conclusions based on those studies alone. The CASP standards that I quickly reviewed for you, they're very comprehensive. Again, they cover caseloads and supervision of technicians by professional behavior analysts and treatment dosage and the scope of treatment, every aspect of ABA services for people with autism throughout the lifespan. They're very good. And they've been derived, again, over years, starting in 2012, from reviews by subject matter experts of the best available evidence as well as the best available clinical practices. And so I would urge you to consider, I know you're maybe not there yet in this country, but this would be a good, think of it as a set of benchmarks, right? Something to aspire to using these standards to guide development, improvement in services for people with autism here in the UK and in all of Ireland. Thank you very much again for having me.